Welcome back, everyone, to part 8 of our 15-part masterclass series. We are diving right back into decoding the absolute maze that is shoulder arthroscopy. Now, as medical coders and healthcare professionals, we know all too well that the shoulder joint can be a totally overwhelming area to navigate when it comes to code selection. But by breaking it down conceptually in this explainer, we're going to make it crystal clear. So grab your notebooks and let's get started.
Quickly, before we tackle today's new material, let's anchor back to yesterday's explainer. In Part 7, we focused heavily on CPT 29819, which is the removal of loose or foreign bodies. The absolute biggest takeaway from that lesson was that strict size requirement. Remember, for a loose body removal to actually be separately reportable, it has to be greater than 0.5 centimeters or larger than the arthroscopic cannula itself. If it doesn't meet that strict rule, it just gets bundled right into the primary procedure. Here is our syllabus for today. We'll start with our recap and mission setup, explore synovial anatomy and pathology, break down partial synovectomy CPT 29820, complete synovectomy CPT 29821, go over the key coding guidelines, and then wrap things up with a knowledge check and outro.
Section 1. Recap and mission setup. Entering the joint space.
Section 2. Synovial anatomy and pathology, the foundation of the shoulder joint.
You know, before we can accurately code any kind of surgical resection, we absolutely have to lock down the anatomical foundation. You literally can't code what you don't understand clinically. So what exactly is the synovium? Well, it's this incredibly crucial, specialized, fluid-secreting membrane that lines the inner surface of the joint capsule. Think of it as the ultimate biological lubricant. It's what keeps the humerus, scapula, and clavicle moving smoothly against each other in this highly mobile ball and socket joint. Without a healthy synovium, every single movement of your shoulder would involve agonizing bone-on-bone friction.
Now, when that synovium gets diseased, it creates some massive clinical headaches. Acute or chronic synovitis causes joint effusion, intense pain, and a severely restricted range of motion. We also see chronic inflammatory arthropathies like rheumatoid arthritis, conditions like synovial chondromatosis, and even synovial neoplasms or tumors like PVNS, which is a tenosynovial giant cell tumor. When conservative treatments totally fail to resolve these conditions, the result is the surgical intervention we're focusing on today.
Section 3. Partial synovectomy. CPT 29820, localized surgical resection.
All right, the official CPT descriptor for code 29820 is arthroscopy, shoulder, surgical, synovectomy, partial. The key word here, your absolute anchor when you're reviewing documentation, is the word partial.
So structurally, how does this actually play out in the operating room? First, the surgeon inserts the arthroscope to inspect the joint capsule and membrane. Once they spot the damaged tissue, they introduce their instruments, which is usually an arthroscopic motorized shaver or an electrocautery wand. Then, they perform a localized excision of the inflamed, hypertrophic synovial tissue. This means they are only targeting a very specific focal compartment or a limited area of the shoulder joint that's causing the patient pain. It's a targeted surgical strike, not a total joint cleanout.
Section 4. Complete synovectomy. CPT 29821, comprehensive excision.
Okay, so when exactly does a focal, localized resection escalate into a comprehensive total joint procedure? Notice the distinct shift in the official descriptor for CPT 29821. It reads arthroscopy, shoulder, surgical, synovectomy, complete. That single word, complete, changes the entire clinical scenario and, more importantly for us, the coding requirements.
In the manipulative field, complete literally means a massive pan-compartmental excision. The surgeon isn't just fixing one painful spot anymore. All the diseased tissue across every single recess, we're talking the anterior, posterior, superior, and inferior recesses, plus the axillary pouch, is methodically debrided and excised. Clinically speaking, this extensive approach is usually reserved for widespread chronic inflammatory diseases like severe rheumatoid synovitis or for a complete tumor excision.
Section 5. Key Coding Guidelines, the Coder's Rulebook.
This side-by-side comparison is arguably the most critical takeaway of this entire explainer. You need to lock this into your memory right now. Partial, which is coded as 29820, always means focal and localized. Complete, coded as 29821, requires a total, pan-compartmental wipeout of all visible synovial tissue. If the operative report just says something vague like synovium was shaved without detailing a total joint sweep, you absolutely must default to the partial code.
Now, here is another massive trap for coders: confusing a simple biopsy with a true therapeutic synovectomy.
You have to verify the surgeon's intent here. Did they merely take a tiny sample of the synovium just to send off to the pathology lab? Because if they did, that diagnostic synovial biopsy bundles straight into the diagnostic arthroscopy code 29805. You do not code a synovectomy for that. To legally report the therapeutic codes 29820 or 29821, the documentation has to explicitly prove an active excision and debridement of inflamed tissue was performed as a primary treatment modality.
To keep you out of the denial pile, we've put together this documentation checklist. You strictly need to hunt through the operative report for these specific keywords. Look for terms identifying the exact extent of the resection and the specific compartments they addressed. Keywords like localized or focal will point you straight to 29820. But if you see power words like total, all visible tissue, or pan-compartmental, those legally justify escalating your claim to the complete synovectomy code 29821.
Section 6. Knowledge check and outro. Test your mastery.
All right, let's put all this to the test with a real-world scenario. We have a patient with severe rheumatoid arthritis. The scope goes in, and the surgeon finds extensive hypertrophic synoviitis throughout the entire anterior, posterior, superior, and inferior joint spaces, as well as the axillary pouch. The surgeon then methodically resects all visible synovial tissue throughout the entire shoulder joint. Based on those keywords we just talked about, what CPT code should be reported here? Take a quick second to think about it.
If you guessed CPT 29821RT, you hit the nail on the head. Awesome job. The rationale here is rock solid. The documentation clearly supports a total pan-compartmental resection of synovial tissue across all the recesses of the shoulder joint to treat a chronic inflammatory condition. This definitely wasn't just a focal cleanup. It was a full, complete synovectomy.
You have officially conquered the synovium today. But our masterclass is far from over. Make sure you join us for Part 9, where we will finally demystify the absolute nightmare of limited versus extensive shoulder debridement. We'll be breaking down CPT 29822 versus 29823 and identifying exactly how discrete structures impact your coding. Trust me, you do not want to miss that explainer.
So the next time you're staring down a shoulder arthroscopy operative note, ask yourself a very simple question. Did the surgeon just trim away a localized problem, or did they painstakingly clear out the entire joint space? As the lines between these codes might seem thin, they carry some seriously heavy compliance weight. It really makes you wonder, what other hidden bundling traps might be lurking in your operative reports right now? Keep those keywords in mind, keep your documentation tight, and as always, decode healthcare with Harshal.